Hello, and welcome back to Season 2 of Health Talk, the show where we explore health challenges that matter most to you, our listeners, and provide the knowledge you need to live your best, healthiest life. I'm your host, Dr. Desmar Walks, family physician, Austin Travis County Health Authority, and medical director for Austin Public Health. Today's episode covers diabetes and cardiovascular health. In this episode, we'll be discussing a topic that affects millions of people around the world, diabetes and its critical link to cardiovascular health. Joining us in this very important conversation is our special guest, an expert who knows and brings decades of clinical experience and research insight on both topics. Diabetes is a chronic metabolic disease that has seen a dramatic increase globally over the last 3 decades. According to the World Health Organization, approximately 830 million people have been diagnosed with diabetes worldwide. This disease, if not managed properly, can lead to serious long-term health complications. Among the different types, diabetes type 2 is the most common, especially in adults. According to the American Heart Association, individuals with type 2 diabetes face a significantly higher risk of developing and dying from cardiovascular complications such as heart attacks, stroke, heart failure, and even memory problems. Our guest today is Dr. Tom Blevins. He's an endocrinologist with a passion for diabetes research and education. Dr. Blevins is a graduate of the University of Texas at Austin, Plan 2 program, and Baylor College of Medicine in Houston, where he earned his medical degree and completed his training in Internal Medicine and Endocrinology. He has practiced at the Austin Diagnostic Clinic for 15 years before founding Texas Diabetes and Endocrinology in 2001, a practice that's dedicated to the diagnosis and treatment of diabetes, thyroid disorders, and osteoporosis. It's an honor to have him with us today. Welcome, Dr. Blevins.
Dr. Walks, thanks for having me here, Desmar, and thanks for all your work with the Health Authority.
Oh, thank you. Thank you. So let's get started because there's a lot to cover. Diabetes is huge, as we talked about earlier.
Yeah.
So let's start with the basics of diabetes. First, can you give us some background on the practice of endocrinology and how it relates to diabetes?
Yeah, endocrinology deals with hormones, and so how does it relate? Diabetes, well, diabetes involves the hormone insulin that has effects. It's produced in the pancreas, a gland, sort of, and it goes throughout the system and has effects in various organs like liver, muscle, fat, and even maybe the brain. And so diabetes kind of fell into the hormonal zone of endocrinology, and then the metabolism part certainly has a lot to do with metabolism, diabetes, insulin, and all of that. So we got diabetes in the endocrinology area. And we're happy to have it.
How would you define diabetes?
Well, diabetes originally was kind of defined based on a sugar level. It's all about the sugar. Mm-hmm. And I may say glucose a few times, that's the same thing as sugar. Mm-hmm. And so diabetes was defined as the level of sugar, and I'll say elevation, that was associated with like damage, complications, damage to end organs like eyes, kidneys, and nerves, and things like that. So that's kind of where the numbers came from based on a bunch of different studies. Now, specifically, I would define diabetes nowadays as being a fasting blood sugar. I can give you a number. I can be very quantitative. That's kind of qualitative in a way, but quantitatively, a fasting glucose greater than or equal to 126 twice, a hemoglobin A1C, and that's that 3-month average test. We call it the A1C, the hemoglobin A1C, that is greater than or equal to 6.5 twice, and that numerically is how we define it. And there's another way to define it too, and that's a glucose tolerance. I won't get into that where you swallow the glucose. Nobody likes that, and we don't use that very often. Mm-hmm. But so that does lead to the idea that, and where you're going on that is, it's important that people know their number and know what their sugar is. The only way you can do it is have it tested. And so people need to be sure and know if they do or don't have diabetes.
That's so true. There are several different types of diabetes. Can you give us a primer on the various types of diabetes and the risks associated with those?
Yes. You know that there are a number of different types of diabetes, and there's the general types we'll talk about: type 1, type 2, and I'll say gestational too, like during pregnancy. And so the fundamentals of type 1 diabetes would be that people with type 1 diabetes don't make any insulin from the pancreas. When I talked about the pancreas earlier, the pancreas in the islet cell, in the beta cell in the pancreas makes insulin. And then that insulin has effect. Well, people with type 1 diabetes don't make any insulin. And you know, type 1 diabetes tends to occur in younger individuals, but I'm gonna correct my statement in a minute by telling you that it seems like it occurs in kids a lot. It does, very dramatic when it does, but most of type 1 diabetes, and I want the audience to know this, is actually diagnosed in people who are over the age of 20. So if you're older, it doesn't mean you don't have type 1. You need to get tested for that, and we do various tests to kind of distinguish type 1 from type 2. So type 1, no insulin. You have to take insulin, really, to survive, and we're pretty good at that. We can talk about that later. Type 2, people with type 2 diabetes does tend to occur in adults, but some children get it too. And in type 2 diabetes, the pancreas doesn't make enough insulin. It makes it. It doesn't make enough. And people tend to have resistance to the insulin, and that's associated with various things we'll talk about too here in a minute. And so there's type 1 and type 2. And again, it's important that people know their numbers so they know whether they have diabetes, period. And then they need to have it distinguished between type 1 and 2. Gestational occurs during pregnancy when the people enter pregnancy, usually in the second or third part of pregnancy. The placenta makes hormones that antagonize insulin. They cause insulin resistance, so it causes typically it's a temporary diabetes, and we call that gestational.
Thank you for that answer. So we're talking about sugar diabetes, as we call it, and people will want to know, is this a hereditary disease?
Yeah, you know, the answer is yes. And so is what predisposes, or how can people kind of identify if they have a risk for diabetes? Is it heredity? Yes, runs in families, both type 1 and type 2. Interestingly, type 2 more than type 1. And I'll say that there are other risk factors for diabetes that people should think about too. So heredity. So if a person has a sibling, brother, sister, parent, aunt, whatever, relative with diabetes, they better be thinking they need to be testing themselves for sure at any age. And so the other risk factors would include age. And you know, it turns out that as you get over the age of 60, 65 and been there, then you have a higher risk. It's true. And then it's this nature and nurture thing. There's definitely nature, heredity, nurture also. And then also ethnicity, Hispanic, African American, higher levels of risk of diabetes, especially type 2, but not exclusive, some type 1. So there are certainly other risk factors. Lack of activity or sedentary lifestyle is another reason for it. And then weight gain is a big one. That's the big nurture thing. When people gain weight, they become insulin resistant and they develop diabetes more often. So there are quite a few different, heredity is a big one, but if someone doesn't have a family history, they're not scot-free, they're not off-free, I should say.
There's a long list of other things that can impact that.
Yeah.
What are some of the early signs and symptoms of diabetes?
Yeah. So a person might want to know, what is a symptom I might have, an early sign, as you're asking. And I'll say this. The sneaker is that when a person's blood sugar starts rising and becomes elevated into the diabetes range, it may not be very high, and they may not have any symptoms at all. So the sneaker is that if a person doesn't have symptoms that I'm about to talk about, you're not off either. Go get checked. Find out because
get your sugar checked.
Get your sugar checked. Yeah. So if the sugar's like 130, 140, fasting. Remember I said greater than or equal to 126 is diabetes. 130, 140, there are no symptoms. But once the sugar gets up over 200, like starts really rising, then a person might develop blurring of vision. The sugar kind of diffuses into the lens of the eye, they get blurred vision. And also, when the sugar is elevated, people sugar goes out in the urine, they urinate more, and so they might urinate more often. I want to say pee more often, but we say urinate, and then drink more fluid, because it makes them get a little dehydrated when they urinate more fluid off.
So they get thirsty.
They do.
Yeah.
So they actually get thirsty. They actually lose weight because there's sugar going in the urine. Sometimes that happens. And then, there's that drive to drink more fluid, and unfortunately many times when people have that drive to drink more fluid and they don't know what's going on, then what they do is they drink more carbohydrate containing fluid, like sodas and Big Chief and things like that. I mean, and they run the sugar up even higher.
That's no good.
That's not good.
How does diabetes impact your cardiovascular health, your heart health, the vessels in your body?
This is a big one, and we were talking earlier that many of the people in the hospital with heart issues, I think their main issue is their heart. Their main issue is really the blood sugar. Many cases, not all, the blood sugar that led to the heart risk, and then the heart disease gets manifested when they go in the hospital with whatever, heart attack or that. But diabetes is associated with many other heart risk factors, and diabetes itself is a risk factor for heart disease, and that's important for people to know, and that's why you're asking. And the diabetes is associated with high cholesterol and high triglycerides, which is the fat in the blood, kind of part of the cholesterol lipid thing. Also, diabetes is associated with more high blood pressure, and that's of course a risk. And then low HDL is very common. High density lipoprotein.
The good cholesterol.
The good cholesterol is low, and that increases risk. So diabetes itself is a risk, but also it associates with a group of risk factors. And some of those are related to the weight that led to the diabetes. It's a tangled web.
So how would you define cardiovascular disease? Talk a little bit about how diabetes is interacting with that blocking of those vessels.
Yeah. Cardiovascular disease, how would I define cardiovascular disease? It's pretty much inflammation, plaque, blockage, problems with arteries from head to toe, including above the neck, cerebrum, brain, strokes, TIAs, things like that, or just decreased blood flow, heart attacks, things like that, and need for surgeries and angioplasties or stents or all that, and also blockage of the arteries in the legs, in the peripheral. So it's peripheral, cardio, and central or cerebral, and so all of those vessels can get blocked, which can lead to major problems. So, we can amputations are higher risk in people that have that blockage in the arteries in the legs.
How can a person who's been diagnosed with diabetes proactively combat the cardiovascular impacts? How can they prevent the heart attack, the stroke, the loss of a limb?
Yeah, so when people come in with diabetes, they many times ask that very question, how do I reduce my heart disease risk? Or if they don't ask, I'm going to tell them. Because it's what you said, it's such a big deal. It's such a big part of cardiovascular disease. Well, part of the way they can reduce their risk is they can reduce their risk of their diabetes getting worse too. And it's kind of reduce the risk of cardiovascular by treating your diabetes. Part of that is exercise, and that's important. Exercise improves insulin effect in the muscle, and that's one thing. Building muscle, aerobic exercise, and some resistance exercise can help that. And that's going to help reduce cardiovascular risk too, by improving diabetes and by also improving cholesterol and blood pressure and all that. Weight loss is a big one, and I should have started with weight loss, but weight loss is a big one. So reduce your diabetes, or get your diabetes control better, you're going to get your cardiovascular control better by losing weight. Everything gets better with weight loss, everything. And then also controlling the risk factors with medication, like blood pressure medications. Treat the cholesterol aggressively. All of the data currently says treat the cholesterol in people with diabetes. and lower it very assertively. And I mean, aggressively is one word. I like assertively too. Either one works. And then we have some medicines that treat the blood sugar that actually help the heart nowadays. How interesting. Medicines like the ones, I'm not going to name names, but people see advertisements on TV of people dancing and things like that. Those medicines. Like the one's called the sodium glucose cotransporter 2, SGLT2. And those are the medicines that people, it's a pill. These injectables we have that are the once a week ones, like the GLP-1s, and the ones that are GLP-1, GIP, those. People know about those. They're once a week. And I can name names there, semaglutide, tirzepatide, all of those, and dulaglutide. All of those have been shown to reduce heart disease risk. In fact, just this past week, one of the studies came out that showed that tirzepatide helps reduce heart disease risk in people with known heart disease. And that was true already of semaglutide. So yeah, there are lots of things people can do.
Which is great.
It's
right?
great.
Sugar doesn't have to be a killer. It can be something that we manage well. Yeah.
It's true.
So how does diabetes affect brain health, including cognitive function and the risk of conditions like dementia or stroke?
Yeah. You know, this is a very thick topic, I think. How does diabetes affect brain, cognitive, all of that? This is a very important topic, and some people have called dementia even a type of diabetes. I'm not so sure I totally get that, or go with that, but the answer is that all of those risk factors we talked about that can cause cardiovascular, remember the cerebrovascular, blood flow. Brain needs blood flow and oxygen to do well. And blockages in the big vessels and small vessels that are not really very helpful. And high blood sugar may cause some cognitive dysfunction in and of itself. And so it's a long, long topic. And actually out of control diabetes is associated with memory issues, cognitive issues, and so that's important. And also hypoglycemia that's caused by some of the medicines like insulin in particular could lead to some changes in the brain over time. So big important area. And I'll just go back to the idea that controlling your diabetes and your risk factors and exercising and keeping the weight as good as possible, all those things are going to help. Sleep apnea is connected to diabetes because the overweight that leads to sleep apnea leads to diabetes.
Right.
As you know, and so that too can cause some brain issues. If your oxygen level is dropping overnight repeatedly, then that's not good for the brain, not good for the heart either.
So really and truly, it's so important to keep your sugar levels normal.
Yeah, yes.
What can people do to reduce the chances of getting diabetes, particularly those with high risk factors like genetic predisposition because their auntie has it?
Right.
Yeah.
So how do people reduce their risk of diabetes? The answer is, well, and what the question you came up with earlier is so important, and that is, what are the risk factors for diabetes? And people can, first of all, and what is the definition of diabetes? First of all, people need to know their risk, and they need to know if they have a family history that they are at risk. And they might want to get their sugar, they do, not might, but they do want to get their sugar checked. Find out if they have high normal sugar, glucose, or prediabetes. People with prediabetes don't have diabetes, but they have a high risk of going on to develop diabetes. So at the point that they see that risk, or they see risk factors accumulating, like they have a family history and they have weight issue or blood pressure, all that, they need to work on reducing their weight, exercise. This really has a lot to do with diet, and low carb is probably a good way to go for them. Low simple carb, which includes, and I always tell people this, potatoes, pasta, rice, bread. And I usually say potatoes, pasta, rice, bread, because bread is so many things. Tortillas and bread is, people love bread. And so I talked to them about that. Fruit has a lot of carb in it. Fruit's good for you. Generally speaking, if you have diabetes or prediabetes, you might want to cool it a little bit on that. And so the diet's a big deal, exercise is a big deal, controlling weight, and those are all very, very important things. And there is a medicine that we use, metformin, in people who have prediabetes, and it's a very inexpensive med. We've used it for a long time. It's been around forever. And sometimes we use that actually to intervene and jump in and try to reduce the sugar in people who have prediabetes.
So everybody should be getting their sugar checked at some point,
Yes.
and those with risk factors
Exactly.
should definitely get checked, right?
That's right. And then that's exactly right. They should check and then check again and then check again. The risk doesn't go away.
So, I just want to make a real point about this because I really want listeners to understand the importance of heart health as it relates to diabetes. What should people do to increase or improve their heart health if they're at risk for diabetes?
Yeah.
Exercise?
Exercise is very important. Aerobic exercise, and you don't have to be a marathon runner. 150 minutes of walking per week, in addition to your normal walking, is one way to do it. And also any exercise, aerobic or even resistance exercise, and controlling weight. Weight's so tough. I mean, controlling weight is so difficult. We're surrounded by food, and the metabolic rate, doesn't compensate for it most of the time, and the metabolic rate drops as people get older. And so metabolic rate is an issue, but we don't have a way to manipulate that really yet. Exercise can increase it a bit. So exercise helps, and just reducing caloric intake. Unfortunately, I hate to tell everyone that. And smoking's a bad one too. So if people want to reduce their cardiovascular risk, don't smoke. Quit smoking.
Yeah.
Yes.
Are there certain questions that people should ask their doctors or clinicians when they go to be checked? Are there specific tests that you would say they should be asking for?
Yeah. So the question is, what tests should people be asking for relating to their blood sugar? Yeah. And it's all about numbers, really, and it's about testing. And so doing a sugar, glucose, fasting is what people should ask their provider or doctor person to check. And people might even want to ask, what is my sugar? And how does it rate? Is it normal? And also, should I have an A1C? The hemoglobin A1C, that's the test that looks back 3 months at the average blood sugar. Seems kind of strange that we can do that, but we can. A1C looks at the sugar attached to one of the hemoglobins in the red blood cell. So you can draw blood. In a way, when you draw blood, you're doing a tissue biopsy because you're getting live cells, and the sugar passes the membrane of the red cell. Red cells live 3 or 4 months, so you can look at a certain hemoglobin that attaches sugar, as you know. I'm explaining for the audience, and you can look back 3 months at kind of an overall blood sugar. It's really cool, and so people should ask, should I have that test? Or do I have that test? Did I have that test? What did it show? Yeah. And then, not just once, but keep asking and do that test over time. That's a really commonly done test.
If someone is diagnosed with diabetes, what types of interventions do you recommend that they receive?
Yeah. Really, number one, I'm going to tell them, it kind of depends for one thing. If somebody's sugar is really high, I might go right to insulin, and if the sugar is kind of moderately high, I might go right to medicine. We don't have to go to medicine immediately necessarily, but many times we do, depending on the findings. So it kind of depends on how high the sugar is. But everyone gets education on diet, hopefully, and reduction of calories and diet components like carbohydrates and all that. And exercise is important. Not everybody can go out there and exercise. If somebody has joint issues, they just need to do what they can do. Maybe they can swim. It's not so straightforward. Not everybody has a pool. When I say that to a person, oh, you can go swim. Well, they don't have a pool. And so any activity is good. Move around. We do use medicines. We use pills. We have medicines that are pills, and I could go through that. But I'll just generally say we have some new medicines in the past many years that are so wonderful. They work so well. And we have some medicines that lower the sugar and lower the weight. And those are those medicines like the semaglutide or tirzepatide type meds. We have medicines that protect the kidneys. It's a big deal for people with diabetes or who just have been developed.
The heart.
Yeah, the heart, exactly, and they protect the heart too. The SGLT2 meds and the GLP-1 meds. And so we have lots of pretty interesting meds to use. One thing that I really like people to do, they need to monitor their sugar. And how can they know how they're doing unless we tell them how to monitor what's going on and do it at home, and tell them what the right numbers are. Well, they can't. So they need a way to do that. We do these finger stick things. We get the blood and put it on the strip, but also increasingly, we use continuous glucose monitoring. And I really want to say, when you ask me that question about how we treat diabetes when people are newly diagnosed, I want to say continuous monitoring, continuous monitoring, continuous monitoring, because those are you all know this is those patches you see people wearing out in the restaurant around town, at the store you see it, or you wear it yourself, or you know about it, and those patches, the different continuous glucose monitors. That little filament goes under the skin. The little monitor transmits a message to the telephone or to a reader, and it tells a person what their sugar is, and it reads every 5 minutes. That's wonderful, because I could drink this coffee if I had sugar in it, and I would see my sugar go up, and I would then know, oh, that made my sugar go up. Or I could have a banana and see my sugar go, and I go, oh, that's something that's going to cause my sugar to go up. Or certainly like a pizza, pizza with sugar would go and stay up. So the continuous monitoring, the problem with continuous monitoring, there's no problem really with it, but the challenge is access to it. People who are on insulin get it covered by their insurance. People who are on some of the other injectables get it covered, but other people really don't, so they'd have to pay for it. But I'll tell you,
but it's a game changer.
It's a game changer.
Because as you say, you can see real time, this is what's happening when I do this.
That's exactly right.
Make those connections.
You can see what goes on inside your body. It's been going on inside your body since you were born, but you didn't see it. Now you see it. The truth will set you free. I think that's on the UT Tower. Is it truth will set you free or something? Or is it knowledge is power? I forget.
Are the interventions for type 1 diabetes, often associated with juvenile diabetes, different than the other diabetes diagnoses? So do you treat it differently?
Yeah, do we treat type 1 diabetes differently? We do, because people with type 1 absolutely need insulin. And I will tell you, as you know, and the audience, that people with type 2 also may need insulin. I treat lots of people with type 2 who need insulin, but it's not required for them to live. It's required for them to live well, but people with type 1 have to have it because they have a total deficiency of insulin. So it's important to distinguish at the time of diagnosis, and sometimes it's not so clear whether a person has type 1 or type 2, because people with type 1 will need insulin. Many times at the time of diagnosis, people with type 1 still make insulin. So they'll do okay with little amounts of insulin, or sometimes they get off insulin, but then the beta cells that make the insulin tend to decline after that. And there's a lot of research going on to try to find ways to preserve those. But you're right, the people with type 1 need insulin.
So does early intervention help prevent long-term cardiovascular issues? So if you start treating your sugar earlier, are you less likely to have problems with your heart or your kidneys or your brain?
There's some really good data. So the question there is that if you jump in and really control the diabetes well, and does it have a long-term effect? We know it has a short-term effect. Does it have a long-term effect versus not controlling well and catching up later on? And there is something that's called legacy effect, and that means, yes, there is evidence that if people control their diabetes promptly, assertively, early, and keep it that way, that they have benefits or advantages later on versus someone who doesn't. And that's a big deal. It's kind of like memory.
What factors in healthcare prevent individuals from getting the proper diagnosis and treatment for diabetes?
Yeah, I think it's knowledge. I think the things that might cause a person to not get the right diagnosis initially and the treatment initially, which is your question. I think that it's knowledge, education, and we all live with a certain amount of denial in our lives. We all say it can't be me, and people need to understand that they might not want to have diabetes, but if they have it, they need to know, and it definitely could be you. So I think that's part of it. I think there's some issues with access and availability of medications, costs of medicines. These new medicines are so wonderful. they're expensive. And you know, if someone doesn't have insurance coverage or ability to get the meds, then they're not going to get them as easily. They might get them. And so expense is part of it too. So access to care, being aware, and then access to care once you're aware, and getting the right testing done, and then getting on the medications, and you know, there's this continuum of potential challenges along the way. The practitioner needs to be up on everything too, and you know, sometimes the symptoms, early symptoms of diabetes, or people have issues and they don't get their testing done like maybe they could, and so it's important that we as practitioners do the right thing and do the test. Yeah.
What are the costs associated with diabetes?
The costs associated with diabetes are enormous, and in fact, I think it was estimated that 1 in every 4 healthcare dollars was spent in treating diabetes is direct or indirect cost. And so the cost, well, you know, we talk about the cost in terms of dollars, and it could be, I think 1 year recently it was like 400 million, and 300 million of those were direct and about 100 indirect, meaning like if people have diabetes and they're having trouble, they're out of commission, debility, disabled, not productive, that kind of thing. And so it's enormous. It's not only meds, hospitalizations, but it's that debility and disability. But to the individual, the cost is health. I mean, it costs them their health, it costs them
their livelihood,
and it costs their families.
And sometimes their lives.
Having them around sometimes, having them healthy.
Yeah. Are there any specific considerations for providing diabetes care in rural or remote communities with limited access to healthcare resources?
Yeah, so what about rural, remote communities and access to healthcare? You know, there's a lot to say there. And I know I grew up in a town that had like 1,500 people, and there was one doctor who took care of everything, and I don't know how he did it, but he did PD, he did everything. And so there was access, but you know, can he really do everything? And I don't know. And so I think there are many places that have fewer people who provide health care. So that's one thing, and that's a challenge. And so getting their diabetes or diagnosed or taken care of could be a real challenge. They can drive off to the big city down the road, but that may not be possible or feasible, or affordable, any of that. So it's a real challenge. I do think, now this is no grand solution, because there's no grand solution. There's going to be a lot of work done there. But I think telemedicine is a way to, you know, I think hopefully the system will continue to endorse, embrace, and fund telemedicine, because I think it has the ability to bring, it doesn't have to be a specialist, but just bring medical care to people. I mean, I can't reach through the camera and examine somebody's thyroid, you know, when I do a telemedicine, but I sure can talk to them about their symptoms and their conditions, and I can send in medicines, you know, and I can look at their blood sugars, and they can communicate with me what's going on. And so I think that's got a lot of potential.
Just talk to me a little bit about emerging research. Are there any promising new treatments or research developments in the field of diabetes that our listeners should be aware
of? In terms of new developments and research in the area of diabetes, the different types, our listeners should be very enthused and very encouraged, because a lot of good meds are being looked at. They may not make it through, they're being researched. Like the next semaglutide, the next tirzepatide, those are those weekly injections, you know, GLP-1, GIP, all that, that help people lose weight and control their diabetes. Those they're next generations of those coming out, and that means a whole bunch of things. One, they may be better, they may not be. They may just turn out to be another option. And once enough of them get out, then
cost will go down.
Cost will go down.
Yes.
Thank you.
Yeah.
That's exactly right.
Yeah.
So in the type 2 world, I think that's going to be big. It's already really, really big. And you know, one thing that's important too is technology. technology is being really developing and coming forth quickly. We already have insulin pumps for people with type 1 that infuse the insulin gradually.
Yeah.
And then we have sensors like those continuous glucose monitors that talk to the pumps. And then the pump starts answering the question of what to do with that blood sugar. So it does it automatically. It's like almost like an artificial pancreas, not quite yet. And so that's coming along
That's huge.
quickly.
Yeah.
We tend to identify that more with type 1. And you asked a while ago, are there different interventions? And I didn't even talk about insulin pumps. Shame on me, because the technology of diabetes is huge in type 1 with pumps. And we have implantable sensors now too. Anyway, the bottom line is the technology is coming along too. You think technology is for the big companies, but it's also for medicine. You think it might be for maybe some robotic surgeries, but it's for diabetes too.
Which is nice.
Which is really nice.
Yeah.
And we're getting some new things in type 1, medicines that might rescue the beta cells,
Which would be
delay
nice.
diabetes if
Yes.
people know they have the risk for it, type 1 diabetes.
Yeah.
And also, well, for one, I mean, some things are really exciting and all that, and some are just more usual, but we have weekly basal, that is that kind of insulin you take usually once a day, weekly versions of that come out before too long. And we may even have a monthly version of GLP-1 medicine coming out, being studied at least. So lots of interesting intervention going on. And
That you've
research.
been involved in, because you've done a
Yeah.
lot of research
Yeah.
in this field.
We have.
Thank you for
Thank
that.
you.
Yeah. Are there any trends or conditions you're seeing more frequently in your practice that the public should be aware of?
Yeah, the trends that I see in the practice relating to diabetes in particular would be, we know a whole lot more about weight loss. I mean, this gets back to the more normal, usual stuff, but the weight loss thing's a big deal, and the medicines and interventions. I think some of the trends that are really nice is that patients are becoming more involved in their care, and they're more knowledgeable. I mean, you can go on whatever search engine and use AI to come up with answers to your questions, which I think weaves kind of fact and fiction together. It's a real interesting little mix there. But I think patients are much more informed. That's a trend. There's no doubt. And then the next question is trend-wise for all of us is, where does this artificial intelligence stuff go with managing diabetes and interventions and patient self-education and self-directed care to some extent with guidance from
Their clinician.
professional. Yeah.
Thank you so much, Dr. Blevins, Tom. It's been such a great opportunity that we've had to share this information with the audience. Do you have any resources or books that you recommend for our audience to learn more about diabetes?
No, it's been my privilege. Thank you for asking me. I enjoyed talking with you.
Yeah.
It's a really, really interesting discussion. The answer is, I really don't have a book in particular. There are a bunch of books people could go look. They can go to the American Diabetes Association website and find out some really good information, good resources. And if they want a book in particular, like about exercise and diabetes, about foods and things like that, and about just medicines and about perspectives from people who have diabetes, that's a great place to go. American Diabetes Association.
Right, and it's reputable.
Yeah.
Good.
Yeah, and I do think that increasingly the resources are going to be online.
Yeah.
And like this one, you can go on YouTube and watch this, us.
Thank you.
Yeah, thank you.
That's all the time we have for today's episode of Health Talk. A big thank you to our guest, Dr. Blevins, for sharing his expertise, passion, and experience with us. And don't forget, we want to hear from you. What topics do you want to know more about? There's a survey on KAZI's website and on KAZI's Facebook page where you can tell us what resonates with you. So please share your feedback with us. Thanks again to KAZI 88.7 on your dial and to St. David's Foundation for their support of this program. Until next time, take care of yourselves and each other. This is Dr. Desmar Walks signing off. Be well.